one. You all are live now. Pause for 10 seconds and you can start.
Good evening. Welcome to this Maharashtra Ophthalmology Society's webinar on cornea and special situations in cataract surgery. We have two very eminent panelists today, Dr. Praveen Krishna Vaddavalli, who is a cornea consultant and head of refractive surgery at the prestigious LV Prasad Eye Institute, and our own MOS member, Dr. Sangeeta Wagh, one of the senior most and leading cornea specialists in this part of the country. And before we go on to this seminar that has been done with the Amravati District Ophthalmology Society, so thank you to Dr. Ashutosh Bhuyar for to each and every district of Maharashtra.
Cataract surgery in a post-RK case. Hello.
Yes,
sir, we can hear you.
And the third talk will be by Dr. Bhageshri Deshmukh. And I would like to introduce my team of chairman, co-chairman, and VOS and VOS, and he is also socially very active. Today's chairman is Dr. Anil Harwani, and I welcome also Dr. Anil Dhamodikar sir. He was also the ex-president of Amravati District Ophthalmic Society and also the ex-president of Vidarbha Ophthalmic Society. He is also very socially active. I welcome him, and I welcome Dr. Manish Tote. He was the president of ADOS. He is a very nice human being, very good friend of mine, and whenever needed, he is there to help us. Now I will hand over the proceedings to Dr. Shirish and request him to. I request Dr. Anil Harwani sir to introduce the first speaker and start the webinar. Thank you.
Thank you, Dr. Ashutosh, and thank you all. First of all, I'll thank Dr. Praveen and Dr. Sangeeta for being with us as a panelist, so that all the Amravatians and the ophthalmologists in this region will be benefited from their experience and knowledge. Thank you very much, Dr. Ragini Parekh, Dr. Parikshit, Dr. Pankaj, to be here with us. And without wasting much time, the first talk is by Dr. Pankaj Lande. So I'll tell you something about Dr. Pankaj Lande. He has passed his MBBS in 1999 from GMC Nagpur, and then he did his DNB ophthalmology from Agrawal Institute. He has been trained under the giant Dr. Agrawal from Chennai, and he did his fellowship in cornea and LASIK surgery at Agrawal Eye Institute. He is in private practice here since 2015, and in 5 years of time, he has gained much height in doing all the quality and quantity of work. And his special interest is in lamellar corneal surgeries, and he has done few innovative works, one of which he is presenting here today. And he is very interested in making the videos, surgical videos, and presenting it to all the colleagues of Amravati and around. So I'll invite Dr. Pankaj to start the first lecture. Dr. Pankaj.
Thank you so much, sir. Thank you so much, all the panelists and senior members, to have me here. I will, without wasting much time, I'm sharing my screen and showing some video. So today I will be talking on a keratopigmentation, that is corneal tattooing. So corneal tattooing, all of us are quite aware of. Everybody is doing now corneal tattooing. Procedure is quite accepted. We have learned over a period of time that corneal tattooing can be an easy procedure. It has come all the way through a very rough path of different type of pigments and all. Now the procedure has become quite easy. So I'm just presenting few scenarios where I have used corneal tattooing or keratopigmentation as a method of treatment to improve the patient's cosmesis. In addition, have some symptomless eyes in painful blind eyes like in PBKs. So here is my first case. The interesting part of this case is this lady, her grandson was not able to bear her because of this white eye. This was a painless blind eye with white opacities. So what we did is with LRI blade, we did a pocket, corneal pocket, and introduced a corneal candle soot along with Indian ink in the stroma, and thereby treated this particular case. So I'm just showing a part of surgery. My whole presentation is hardly 8 minutes. So everybody can have a look at it. This is a lamellar pocket dissection, and this is followed by ink. This is a tattoo ink which is available on Amazon, and along with this a soot is also used in this case, as this was a very thick scar. You can see inferiorly in this area that there is still some more anterior stromal scars which will be visible in the post-operative period also, but that's okay. Once this procedure is done, I have completed the procedure by suturing this pocket with Tenno nylon, which was removed 15 days later. This was a pre-operative and this was a post-operative presentation of this patient. So her happiness was there with the surgery is that her grandson is no more fearful to her. So that's the beauty of this procedure. Second case where I have used is we did a scar dissection. She is a very young, nearly 22-year-old female working in office, and always she came to me with a frustrated mind that she is not able to concentrate. Everybody looks at her eye and talks to her. That makes her very uncomfortable. So what we did is this scar was epithelial hypertrophied scar. We checked it on anterior segment OCT. So in all such cases, anterior segment OCT is one such beautiful tool which can be utilized. And we removed this scar, and you can see how easily this scar can be dissected out. Once this is done, we have tattooed this particular area. Again, here I'm using a tattoo gun which is commercially available. The depth of this tattoo gun, the needle, can be calibrated according to the pre-operative pachymetry of a particular corneas, as many of these times these corneas are quite thick. So you can have slightly more depth. This is a tattoo needle, and you can see the movement there. This can be, this procedure is and this is the calibration of this needle. On a machine you can do that very much. And this is very cheap and easy method to treat these patients, and cosmesis is one thing which is like very easily can be achieved with this method. And this is a water soluble ink, so I'm just cleaning the ink and checking whether it has reached to the stroma or not. And this is the pre-operative, and this is the post-operative picture of the same patient. She is quite happy. This is with the light on, so it is quite visible, but without any lights, it is like very much normal looking. I have tried multiple color inks also, but in Indian scenarios, I think the black color works best. There is one interesting case which came to me. This was a patient operated for IPCL by one of my friend, and because there was some uniocular diplopia, following which patient following a large PI in a phakic case. Now the question was how to treat this uniocular diplopia, as it was very large PI. So I had a trick to treat this. So what we did is we just tattooed the area from where the PI was there. So I'm not going to show the surgical part over here. I'm just showing the post-op picture. You can see how well it is covered, and it has covered it nicely. The previous picture was not exactly this patient, that was an illustrative image. So by this tattoo method, we have corrected the uniocular diplopia. Otherwise, to put a iris segment and all would have been very tedious and troublesome procedures. But this is a beautiful and very easy procedure to proceed with. Now, taking into consideration pterygium surgeries, many of us are having pterygium patients where corneal scar is already there in our pterygium surgeries, because of which many times patient feels, is my surgery is like failed? Still, after removal of my pterygium, I have a scar. We have large vascular scars, vascular pterygiums like this. Many of us, because we live in a temperate countries, and in a post-operative period, we used to ask me that, sir, why I should have this scar? Even after your successful surgery, you are saying the surgery is successful, but I am not able to satisfy myself, because whenever I look into the mirror, there is scar. So to answer that, what I did is we just tattooed this particular area, this small area of this thing. These are few of the examples. This is the scar which has remained, and this is the scar which has remained, and the patients are not happy. So to get a perfect output after pterygium removal, I usually mark my pterygium area with gentian violet. This is the autograph done, and that small area, patchy area of white opacity is tattooed following this. So this is the third scenario where you can use a tattoo very comfortably, and patient can have a very good cosmesis. Believe me, in Indian scenarios, it hardly matters. Black is the best color ink, which is like quite successfully we can do. And green also, the brown also works good, but that is not needed. Many times browning fades away slightly earlier, I think, where I have to repeat my procedure maybe after a month or so. So I have completed my tattooing, and this is the post-operative picture. This is with the light. When you see the same patient without much of a flashlight, you can see it is like very much normal looking eye without any ugly scar. So there is another one patient who has undergone multiple keratoplasties. A very young 22
Dr.
year
Pankaj?
female.
Dr. Pankaj?
Yes, sir.
Could you wind up? We have reached last half a minute of the presentation.
Sure, sir. Sure. And this is another scenario where I have used tattoo and treated the patient's cosmesis. You can see the pre-operative and the post-operative picture below. Now, in cases of pseudophakic bullous keratopathy, we know that the endothelial ionic pump is poorly functioning, and we have patients where a PBK epithelial edema, and these cases can be tattooed, and this edema don't occur very frequently. You can have lamellar packet and introduce a candle soot in it, and then close it, so that the water from inside, the aqueous humor from inside, don't pass to the level of epithelium and don't cause any symptoms of irritation and pain. So these are the roles. So taking into all this consideration, I really have come to a conclusion that this ink is quite useful, and you can think over this.
विकी बाबू, अभी समय बाकी है। ये कोई मामूली स्याही नहीं है। चमगादड़ के हड्डियों के चूरे को एक सफेद कौवे के मुंह में मिलाओ, तब बनती है ये स्याही।
Thank you so much. Thank you so much. I hope this will be useful, and there are different scenarios where you can use this ink and will be useful to many of the patients. Thank you so much.
Thank you for a wonderful presentation. I request the panelists also to give the comments, and then the chairman, co-chairman also can add in a quick comment.
quickly wanted to just compliment Dr. Lande on his innovative use of tattoo ink. I think a lot of times we don't consider things from the patient's point of view. But from the patient's point of view, when you actually use this tattoo pigment, I think the amount of confidence that the patient gains is, I think, tremendous. And your different approaches as well are very innovative. The pocket method seems that it has the longest lasting effect. The only thing that I would probably do a little differently is in the scar that you had in the second case in the PBK. That is usually more hypertrophic epithelium with subepithelial fibrosis. It tends to come back and usually indicates that there is some endothelial dysfunction in that case. So in actually a more longer lasting solution for those would be to do an endothelial keratoplasty. Of course, in times like this where we don't have adequate tissue, this probably could be a useful substitute. So congratulations, well done, Dr. Lande.
Thank you so much, sir. Thank you so much.
Thank you, sir.
Dr. Sangeeta, madam.
Yeah, I would like to congratulate Dr. Pankaj on the many indications that he has extended the use of tattoo to. And I just had a few questions on the sterilization of the ink. I mean, do you use a fresh bottle for every patient, or do you reuse the ink? And if you do, how do you sterilize it? I mean, this is just for everybody's applications. The ink is available to all of us on Amazon. And second is the source of the tattoo gun. Can we use any of the guns that the cosmetologists or, even in the parlors? Like I was operating a patient and I just kept scrubbing her lids, wondering why the black color wasn't going. And that lady exclaimed to me, she said, "Are you trying to remove my liner tattoo? I got it done 30 years ago in the US." And that's when I realized that there are so many people using the tattoo gun and we are probably the last to have used it. So I just wanted to know from Dr. Pankaj some more information on the tattoo gun.
Yeah, ma'am, tattoo gun is quite commercially available product. We have ordered it from China and got it, means I know you must also have got that at the same time where Aditya Pradhan has ordered it. And the same gun I am using. There are some other guns also which are commercially available, and I think the guns with multiple pins and with a calibration needle is something which we should be looking at. So any kind of gun with that type of things is okay, and these guns comes with a sterile needles, so that won't be an issue. Regarding the sterilization of ink, I usually take 2 to 3 ml of ink in a Trypan blue bottle and autoclave it. Many of the times it has to be autoclaved slightly less quantity because that spills out, that gets slightly harder, but that's not a big deal. In addition, the ink itself is a bacteriostatic, and to have an infection because of the ink is quite a rare phenomena. It has never occurred to me, and I think it works, but still we autoclave every time.
Right.
A small Trypan blue bottle.
And just if I could share my own, the technique that I have followed for the last 30 years. I think Dr. Praveen might have heard it. Am I audible?
Yes, ma'am. Yes, ma'am.
Yes. So, so this is a technique that my teacher, Dr. Ajit Shah, taught me during my residency, and he asked me to open the last few pages of Parsons, the 1984 edition, and there they mentioned use of gold chloride and platinum chloride and hydrogen hydrate. So there I started experimenting, and then I use those even today. Like the gun has been added only recently to my practice, but I've been using gold chloride and platinum chloride with hydrogen hydrate for ages. And I was really amazed when I reviewed the literature recently. These have been described by Dr. Banerjee, like our current Dr. Banerjee's father, and he's published this in the British Journal of Ophthalmology in the year 1930. And this works extremely well, and the inert materials, they can be sterilized and dissolved in sterile water, and the hydrogen hydrate is used as a fixative, and they can last for like decades. Okay. So that was just something I wanted to share.
Yes, ma'am. Wonderful.
In fact, long back, I mean, even I have used this gold chloride and platinum chloride. Dr. Madan Gopal, he used to do the same, and he has taught to me, and I think Anil also remember, Anil Damorikar. I mean, we did a lot of patients tattooing out quite, I mean, maybe around 20 years ago, 20, 25 years ago. And that works really good, gold chloride tattoo and this platinum chloride. So we'll go ahead with the second. Pankaj, will you stop sharing your screen?
Sure, sir. Sure, sir. My computer is not responding. I'm just maybe.
The Entod IT guys can help. The host can actually stop screen
Please
share.
close the program. Zoom meeting is not responding. Close the program.
While there is a changeover happening, I just thought I'll show the tattoo pigments that are available. I think Dr. Pankaj Lande also uses something like this. These are from Amazon. You get different types. The one that is in my right hand is the brown one, actually. A little more natural for people who have lighter irises. The black one, like you correctly said, is the one that lasts longer. Generally, for surface lamellar pockets, the brown one stays in longer, but for surface, black one is probably better. So you can get them on Amazon very easily. Used for typical skin tattoo and single use. These are.
Wow. I know. Everybody can see it. One question I had in my mind, the patient with the PI, when you do tattooing, does it affect the refraction of the patient? Any changes on the cornea? Or
No,
because it will block light or something?
No, ma'am, nothing. As it was very much peripheral and the tattoo was like nearly 300 microns depth inside. So it has not affected any changes in the refractive, no refractive changes it has occurred.
Corneal surface?
Nothing, very much clear, clean, quiet.
There is no irregularity of the surface or anything. Does it happen or it doesn't happen? Does the patient have any
it doesn't
surface?
happen. For sure it doesn't.
These are cataract surgeons' doubts.
No, ma'am. But it doesn't happen. This being this ink is like a water soluble material, it is quite tissue friendly, and I have not seen any patient which has gone for any reactions, any infiltrations of cornea. There is very minimal risk of infection also, I think, and we definitely do take care for any infection also.
Thank you so much.
That was
Thank you so much.
Yes, ma'am.
Thank you, Dr. Pankaj. Anil.
Thank you so much, sir.
Thank you, Dr. Pankaj, for a wonderful talk. Good evening, our eminent panelists. Good evening, the office bearers of MOS. We now move to our next talk. Dr. Naveen Soni, he will be delivering his talk on challenges in post-RK cataract surgery. Before he starts the talk, I would like to introduce Dr. Naveen Soni. Naveen, can you share your screen, please?
Yes, sir. Okay.
Dr. Naveen Soni is a young and energetic, dynamic, and ever-smiling ophthalmologist from Amravati. After completing his MBBS from GMC Nagpur, he did his postgraduate from Nair Hospital, Mumbai in the year 2011. Later, he did his DNB in 2012, and he then did his fellowship in cornea at the Retina Foundation under Dr. Ashish Nagpal. Later, he proceeded for a 3-month short corneal fellowship of ICO at Royal Victoria Eye Hospital, Melbourne, Australia. And since then, he's now practicing in Amravati. He has special interest in keratoconus and refractive surgery. He has many papers in the IGO, and he has presented many papers in VOS and MOS conference. He will now be speaking on the challenges in post-RK cataract surgery. Over to Dr. Naveen Soni.
Sir, thank you, sir, for a nice introduction. Good evening, everyone. My slide is not getting forward.
As you all know, RK was a popular refractive surgical procedure 30 to 35 years back. Now we are faced with cataract in post-RK patients. RK, as you know, post-RK cataract surgery presents a special challenge, not only for power calculation, but also intraoperative procedure also needs some special management. Dr. Naveen will highlight this.
Sure, sir. Thank you. At the outset, I would like to thank ADOS and MOS officials for giving me an opportunity to speak here. Today, my topic is challenges in management of post-RK cataract. As already Dr. Anil sir has told you that radial keratotomy is or was a refractive surgical procedure to correct myopia and astigmatism, very popular in 1990. It involves making numerous radial incisions extending from pupil to the periphery of the cornea in a radial pattern, like a stroke of a wheel. The number of post-RK patients needing cataract surgery is rising because obviously they are aging and so they have more probability of developing cataract. So, what are the challenges in post-RK cataract surgery? Performing cataract surgery on a patient after RK can present a number of challenges for the surgeon. Chief among these are the IOL power calculation, the technical challenge of performing the incision, and the fatigue. IOL power calculation, the important points to consider are getting the right central corneal power, use of special formula, target for post-operative refractive error, and which IOL should be used. So, how we calculate central corneal power? Most topographers available today will do a good job at getting us the central corneal power. We should average the 0 to 3 meter zone, which gives us a very good central corneal value. Next thing we do is to plug these values into the Holland-Digital formula, which is available on most of the new machines, and we should check the yes when it is asked that whether the patient has the previous RK or not. Or otherwise, we can use an ASCRS post-RK formula, which is available on iol.ascrs.org website. With the use of modern IOL power calculation, there is over 80% chances of patients within 0.5 diopter of our target. This is a topography in a post-RK patient, which I had recently done. This is a web page of IOL power calculation from the ASCR website. After filling the general information of the patient, we can fill in the pre-RK data is available. It is not compulsory though. The post-RK data is the most important to be filled in. We can fill in the refraction and then topography values. The most important of which is the 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter zone ring value, the power, which will give us the adjusted central corneal power. After this, we can fill in the routine scan readings and we can calculate the IOL power. So, what IOL to be choose and which IOL power should be used? We should aim for about -1 diopter of spherical correction in post-operative cases, as RK patients often have an ongoing hyperopic. There is always chance of immediate hypermetropia post-operatively due to RK good hydration, depending their central corneal function. We should counsel the patient about the same. If there is a significant astigmatism of more than 2 diopter, toric IOL can be considered only if there is a very regular astigmatism in central clinical zone and we can define as excess. We should try to avoid multifocal or trifocal IOLs in these cases, as there is always risk of eye aberration and changing refractive error. Monofocal or spheric IOL can work best. So, how we do make incisions in a post-RK cases? As we all know, phacoemulsification exposes to an increased risk of dehiscence or rupture of previous RK incision because of an impaired corneal biomechanics. We should focus on careful assessment of the incision, evaluating the space between the RK incision, avoiding to intersect any RK incision. We should avoid clear corneal incision and make them as posterior near lingual as possible. A scleral phacotunnel can also be used. We should prefer to do a MICS to detect the main corneal bone incision, and we should approach from temporal area precision. So this is how a 16 or 20 RK cuts patient will look like, and in these cases it can be difficult to have a corneal incision, and we can opt for a sterile tunnel incision for phacoemulsification. In case if RK incision is transected by our surgical incision. Significant instability of wound can happen, and we should immediately suture it with a 10-O nylon. How we proceed with phaco in post-RK cases? Key is to just maintain our normal technique, keeping it a little lower flow to keep the pressure in the eye down as we work. Slow motion, slow flow, phaco chop work best in this case. You should also remember that this patient were once myopic in infection and still have the ocular anatomy. So all the risk of cataract surgery in myopia will still apply. The RK incidents can confuse us during capsulorhexis, so it is preferable to use a capsular. I am sharing a video of my recent experience with the post-RK case. Here is a video of a case of cataract surgery done at our center 2 months back in a 16 cut post-RK case. RK was done more than 25 years back. Pre-RK details are not available. Incisions have been made as posterior as possible near the lymphus. The axis is done as usual. I have not stand here because I was comfortable by doing the rest. We can stay in the anterior capsule before rest. This is a fast forwarded edited video, so you might think that I am doing it very fast, but not normal. After doing a capsulorhexis, as I was able to get the adequate space for my main corneal wound, I had done a corneal incision only, and I have not intersected any RK incision by doing my main corneal incision. Hydrodissection and hydrodelineation procedures are done as usual. This is a 2.65 millimeter corneal incision. I have proceeded with my phaco as usual. I am doing a phaco chop. Bottle height is little lower than a normal looking case, and I am using a lower flow than a normal case. We should prefer lower flow and lower bottle height. A smaller phaco needle to ensure that the fluid inflow will stay greater than the fluid outflow to maintain the anterior chamber stability much better. As we can do the phaco surgery. Here I have used 30 ml per minute flow rate, 300 vacuum, and 30 power in a phaco chop mode. After this, we can do a thorough cortical cleanup and polishing as per our routine. I usually prefer to do a bimanual irrigation and aspiration as I have been taught from my higher age. I generally do PC polishing with my eye probe only. Usually I do hydroimplantation of IOL in almost every case, but here I am using viscoelastic to inject the IOL as I will like to avoid the undue stress on the RK inject. I am targeting a minus 0.75 diopter post-operative refractive error in this case. This is a plate haptic IOL. So I have made a little bit larger distance in this case. I will can thoroughly clean the viscoelastic and we can hydrate the wound. In this case, after hydration of the wound, interior chamber was very stable and maintained. So I have not done any fluorescein staining to check my RK incident, as I was comfortable. So, in the summary, we can say that this is definitely a difficult subset of patients for many reasons. IOL implant calculations can get inaccurate, surgical procedure can be challenging, and post-operative recovery can be prolonged. However, the greatest challenge is often the mindset of a refractive patient. Some of these patients have high demand and can be intolerant to any residual refractive error. So, proper pre-operative counseling is of the utmost importance. Thank you.
Thank you, Dr. Praveen, for a great. Thank you, Dr. Naveen, for a great presentation. As you have highlighted, proper counseling, proper IOL power calculation, and proper technique is the key to success in these patients. I now request Dr. Praveen, our panelist, for his expert comment.
I must say that Dr. Soni, you're a very talented surgeon and some excellent video. And also, I think very, very important tips for those of us who are planning to do RK surgery. So if you don't mind, I'll just repeat some of what you said, which I think are the highlights. I think like Dr. Anil sir said as well, the counseling of the patient is probably of primary importance because like you rightly said, even after surgery, there will be some shift of refractive error, early post-op, even late post-op as well. And the more the incisions, the worse this is going to be. And this is a lifelong problem. So patient needs to understand that the refractive error is going to keep fluctuating with RK. The second thing is there is a subset of RK patients who over a very long time, they tend to get some scarring in the visual axis as well. So in cases like that, it's important to ensure that we take care of that scar before we do the cataract surgery and the surface is smooth. The topography that you said is very accurate and the IOL power calculations are also some great tips. I think very important is the aspheric IOLs that you mentioned, as high asphericity as possible because all these high myopic patients who are corrected with RK, they will have extremely flat corneas and very high positive spherical aberrations. So try and use a lens that has as high negative spherical aberrations as possible. I think that will give the best possible visual outcome to the patients. And again, the great tip about making sure that the patients are a little myopic so that these patients are more comfortable than if they turn hyperopic post-op. The only thing that I probably would do a little differently is I probably would use a scleral incision in every case because especially with the 16 incision RK, sometimes even intraoperatively, the incisions open up, AC becomes shallow, and then surgery becomes a little challenging. If you use a scleral incision, because the RK incisions don't extend to the sclera, I think it has more strength, and so surgery usually goes off without any problem. But excellent talk and very good points. Thank you.
Can I ask one question? Can I ask one question?
Yes.
Yeah. What exactly is the difference between a post-RK IOL power calculation and post-myopic LASIK surgery, maybe PRK or LASIK?
Sir,
I mean, how
RK,
do?
sorry.
Yeah.
What I understand is with RK, the front and back of the cornea changes in unison compared to a LASIK or PRK surgery. So it is easier to calculate IOL power in a post-RK patient.
RK rather. So you have to take the actual keratometric reading you mean to say, because that ratio is not changed much, you want to say.
Yes,
As it is changed, posterior to anterior curvature ratio of the cornea, is it changed as it is changed in the LASIK, post-LASIK patient?
Ravin sir can highlight more.
So I think with IOL power calculations in post-refractive surgery, there are two challenges. One is the challenge of measurement, because normally all our K measurements we take not at the center, but in the paracentral area. Now with LASIK or PRK, the change from the center to 2 millimeters paracentral is actually quite a lot. And we don't measure that change. Whereas in RK, the change is more gradual. So the errors in that aspect are much lesser as well. That's why with a regular keratometry, you should be able to get a good calculation. The second point is when we calculate keratometry, the assumption is the posterior corneal curvature is uniform, about -6 diopters that it contributes in all cases. But this ratio, like Dr. Naveen mentioned, in LASIK changes because only the anterior curvature actually changes, whereas the posterior curvature stays the same. So the assumption is the same, but the fudge factor of measuring the anterior curvature and correcting it becomes wrong. Whereas in RK, both the anterior as well as the posterior change, so the risk of error is a little less. So like he correctly said, I think chances of having more accurate measurement and calculation are better with RK than with post-myopic LASIK surgery.
And which instrument you would like to prefer to measure the K reading in post-RK? Because if we do manually, it measures at 3.2, which is larger than the optical zone, and maximum flattening is in the center part. So, I mean, which instrument would be better to give the exact K values in post-RK?
I think ideal would be to use a topography machine and not take the central K, but take the average 3 to 3.5 millimeter K. In some of the common pentacams and all these other machines that you actually get something called the Holiday EKR value. Takes into account anterior and posterior correction, as well as gives you the average K in the 3 millimeter zone. So I think those are the most accurate.
Dr. Sangeeta, madam, any comment from you?
So I agree completely with what Dr. Praveen says. If one has the facility, it is always better to cross-check with 2 optical biometers. Like I have the luxury of having Atharva right down my lane, so I always get a reading on an IL master as well as the Lensa. In addition, like Dr. Praveen said, look at the AKR value on the pentacam. And one of my most rudimentary and very primitive methods, as might seem, I do an on-table retinoscopy at the end of the surgery to make sure I have a as close to possible emetropia as possible. Something about the consent, I have burnt my fingers with post-RK patients in spite of proper counseling. The patient, if he is unhappy, will keep coming back to you and he will threaten you and he will probably hold it against you and say that, you know, he signed the document because you gave it to him on the day of the surgery. So what I always make sure is when I'm counseling the patient, do more than one sitting and also make sure the relatives are there with you. I think in the West, there's a lot of emphasis on video recording of consents just for this very reason, because even though one takes written consents, the patient may just backtrack and say that he wasn't told about all the XYZ problems that can come up. So I would spend extra time with a patient who has had any refractive procedure before scheduling him for the cataract surgery.
Yes. I have one question. If we have a refractive surprise, which additional procedure we can do, and after how much time we can do? Naveen?
Sir, if we have a refractive surprise, we should at least wait for 6 months in cases like this, I think so. And according to the refractive error, we can go for either a laser refractive surgery or a Sulcoflex technique, depending on the refractive error. But nowadays, almost 80 to 90% patients we can get accurately, the IL power calculation can be accurate because of the topography systems and the new formulas which are available.
So I'd like to share another experience. I'd like to just share an experience for the benefit of everybody that your options are, I would wait for 3 months minimum or get 2 or 3 stable refractions, and you can either offer an IOL exchange or a piggyback lens. But while doing a piggyback lens, one must remember that these highly myopic eyes, their HVID or the corneal diameter would be more. And that's why choosing a proper lens, like with no financial interest, I think Sulcoflex is one of the largest diameter lenses one has. This remains more stable and one needs to be sure that you've put the proper sizing of a piggyback lens.
Any more questions?
Yeah, I have a question. Like many of the RK patients have additional incisions of AK also, astigmatic keratectomy. And I have seen 2 cases of mosaic keratotomy also. There are plus signs on that in Amravati itself. And I operated on that patient. Luckily, the patient, the depth of incision was not very great. So I could get quite a good output of that particular patient. But do you recommend or do you have any experience and would like to share something on these two issues? Praveen sir and Sangeeta.
Well, I would say by default, the most common kind of patient who confronts you is the regular RK. The overcorrected RKs that surgeons, they tend to do their own art on the eyes. Like you said, sometimes they're achy incisions, but those also have not found to be too much of a problem from the calculation of the IOL power. The one that you mentioned in the end, they typically call the hexagonal keratotomy, where you tend to have RK kind of incisions made in a pattern that is hexagonal on the eye to correct hyperopia. Those seem to be the most difficult to actually manage. I've had, I think, 2 patients, and both of them ended up having a corneal procedure because of the very small optical zone and very poor visual acuity and inability to actually get a good K reading to calculate an IOL power. So those are rare, but if they come to you, then good luck.
Okay, sir.
I think we should we can continue with the question answer session after the third talk. Shall we move for the third talk? I think we are running out of time.
Okay. Yes.
So the next topic will be by Dr. Bhagyashree Deshmukh. She will be speaking on management of astigmatism in cases of cataract patients. So again, astigmatism control has always been a burning topic in all conferences and every cataract surgeon's day-to-day practice. So before she starts a topic, Bhagyashree, please share your screen. I'll introduce Bhagyashree in briefly because I know we are running short of time. Bhagyashree Deshmukh has done her MBBS from the prestigious GS Medical College and KEM Hospital, Mumbai. She belongs to the 1999 batch. After her MBBS, she has done her DNB from Shankar Nethralaya, Chennai. And from 2006 to 2009, she was at Shankar Nethralaya, Chennai. After that, 2010 onwards, she has joined Deshmukh Eye Hospital. She is happily married to Dr. Himanshu Deshmukh, who is a prolific vitreoretinal surgeon in Amravati, and her father-in-law, Dr. Satish Deshmukh, is the last generation's prolific cataract surgeon, a very high volume and well-versed cataract surgeon. So as the name suggests, Bhagyashree means the goddess of fortune. After marrying Deshmukh family, she has changed the fortunes of Deshmukh family and it has become the topmost institute of the town. So without wasting much time, I present to you Dr. Bhagyashree Deshmukh with her talk on astigmatism control.
Very good evening to everyone. I hope I'm audible to each and everyone.
Yes.
Okay. Thank you, Manish sir, for generous words about me and my family as well. And at the outset, I would really like to thank Maharashtra Ophthalmic Society and Amravati District Ophthalmic Society for having me here. It's an honor to share the screen with all of you. Coming to my topic, cataract surgery has evolved to become a refractive surgery in this modern era. Correcting corneal astigmatism during cataract surgery is instrumental in achieving good refractive outcome. Let's summarize the basics of astigmatism correction during cataract surgery. Basically, wherever you place the incision over cornea, it causes flattening of the cornea along that meridian and the same amount of steepening in the meridian 90 degrees away from it. For example, over here, the incision is causing flattening at the 90 degree meridian from 44 diopter to 43.5 diopters. And this incision is causing steepening at 180 degree incision as well from 43 to 43.5 diopter. In turn, it causes no change in spherical equivalent of cornea. The average K remains the same before and after the incision. So due to this coupling effect, there is no need to change anticipated spherical IOL power when astigmatic correcting corneal incisions are performed. And this surgically induced astigmatism can be deliberately exploited to cause the flattening of steep meridian by on-axis incision. This is the cornea with steep axis at 180 degree. So this is against the rule astigmatism. And if I place my phaco-incision over here at 180 degree, it will cause flattening of the existing corneal astigmatism. The P of 1 diopter astigmatism might drop down to 0.5 diopter. On the contrary, over here, the steep axis is 90 degree. This is with the rule astigmatism. And if I take my routine temporal clear corneal incision over here, it will flatten the already flat meridian and worsen the steep meridian further. 1 diopter astigmatism might increase to 1.5 diopter postoperatively. So placing the phaco-incision at the superior position over here could be helpful with the rule astigmatism corneas. How much flattening these incisions cause is affected by type of incision. The larger incision, the 2.8 millimeter incision, will cause more flattening than the 2.2 millimeter of incision. If you take the incision with very short tunnel length, it will cause more flattening, but it will not be a watertight incision. Chances are more that it will leak. To create an astigmatically neutral, stable, clear corneal incision during cataract surgery, the incision requires to have sufficient tunnel length. If the incision is more anterior, more closer to the center of cornea, it will have more flattening. On the contrary, if the incision is away from the center, more towards the limbal side, it will cause less flattening. And that's why the temporal incision taken in the phacosurgery cause less surgically induced astigmatism than the superior one, because temporal limbus is farther away from the center of cornea than the superior limbus. Adding an identical penetrating clear corneal incision opposite to the first one can enhance the flattening effect. This is called paired opposite clear corneal incision. These are placed on steepest meridian. The best time to make the additional opposite incision is at the end of the cataract surgery. I usually inject an IOL under continuous irrigation. And after that, with the same continuous irrigation, I maintain the stable anterior chamber. This with the 2.8 millimeter steel blade make opposite clear corneal incision. These are the results I usually tend to get. I get 0.75 diopter of flattening in against the rule and almost 1 diopter of flattening in with the rule astigmatism. So paired OCCI, it's a very easy and important tool to have in your armamentarium. For a little higher astigmatism, where due to the financial constraints, if toric IOL is not possible, limbal relaxing incision is a very good option. Surgically, it's not a very challenging procedure. Usually it is done before starting the surgery when globe is still firm. Axis is marked preoperatively when patient is sitting, and with diamond knife, the arcuate shape cuts are given just inside the limbus. There are various nomograms available online. I prefer using this Nichimen age and Pachy adjusted nomogram, and it gives me quite predictable results. Before we go on to toric IOLs, the most reliable option, we must understand posterior corneal astigmatism. It is shown that the majority of population has steep axis of posterior cornea along the vertical meridian, that is with rule astigmatism, which on the contrary exerts an against the rule effect on the anterior cornea. So if the anterior surface has with the rule, the posterior against the rule tends to reduce it. So if we calculate the toric IOL based on anterior curvature alone, it will lead to overcorrection. And that's why the Baylor's nomogram and Barrett toric calculator suggest to select the toric IOL of less toricity and with rule astigmatism. On the contrary, in the against the rule astigmatism, if the anterior cornea has against the rule, posterior against the rule will increase it. And toric IOL selection based on anterior curvature alone would lead to undercorrection, and that's why it's recommended to use higher toricity toric IOL in against the rule astigmatism. For example, over here, the patient has almost 1 diopter of astigmatism of against the rule, and this calculator shows Barrett calculator that she will need toricity of 1.5 diopter in her IOL. And here the same amount of astigmatism, but it is with rule, and calculator shows that he actually does not need toric IOL. She does not need toric IOL, and she will have a good outcome with minimum residual astigmatism. This minimum astigmatism you can actually even dress by on-axis incision. And if I too use toric IOL of minimum toricity, it will overcorrect and actually flip the axis. I usually aim to correct most but not all the astigmatism, because overcorrection of the astigmatism will result in flipping, as in this case, and the patient will not be happy. Recently, Barrett toric calculator has added the option of measured posterior corneal astigmatism. Usually the default setting is predicted PCA, which we have been using. If you have one of the machines which give posterior corneal astigmatism, you can actually enter the value and the calculator will use those values to calculate the toric IOL. But there is inherent difficulty of directly measuring the posterior cornea. It is found that none of these machines consistently make accurate assessment of posterior corneal astigmatism. So another interesting development in posterior corneal astigmatism is intraoperative aberrometry. It allows intraoperative real-time measurement of the aphakic refraction of the total optical system after cataract extraction. Therefore, theoretically, accounting for all sources of astigmatism, including the posterior cornea. So that might be the future to address the posterior corneal astigmatism. So thank you very much for patient listening.
Thank you, Bhagyashree, for your wonderful talk. And I'd like to invite the panel. We'll start with Sangeeta Madam for their expert comments.
So I would put the preoperative assessment the most important, and like Dr. Bhagyashree mentioned, that particular attention to the posterior corneal curvature is extremely important. And I would also definitely put topography in the armamentarium, and obviously, if possible, the optical topographer that's with the Scheimpflug in evaluation and calculation of the patients.
The evaluation and the assessment of the corneal astigmatism, the amount and the axis is the most important thing. But
also,
one more
I think even marking. Sorry, just marking the 3 and 9 o'clock before the surgery is again to be.
Yes. In all sort of incision
carefully.
or in toric IOL, I think marking is the first very important thing. If you mark properly, then everything goes properly.
One more reason to go ahead with Scheimpflug topography images is, once I have found a patient having posterior corneal astigmatism as against the rule posterior corneal astigmatism, only one patient. So if I would not have gone by only Baylor nomogram or Barrett toric calculator, probably I would have overcorrected.
So what did you do? What did you do? You enter those values in the calculator?
Yeah, I entered. I mean, I did not go for that Barrett calculator. I went according to this.
Okay.
Yeah.
Because I have these questions. But whenever I select and actively put posterior corneal astigmatism value, many times that the IOL I get is very different from the predicted PCA. And I tend to go with the predicted PCA more, and it gives me better results now. So anybody else who is using measured PCA and putting IOLs accordingly?
No, I go by only Barrett, but then I just look at the posterior corneal astigmatism on the topographer. And second, more important is these Scheimpflug image topographer, they also give the axis of the total corneal astigmatism, which is sometimes different from the anterior corneal astigmatism. So you can consider that also while calculating the IOL power.
And in toric IOLs, I think the most important thing is your marking. And I think Dr. Harwani can throw some light on the slit lamp based marking system.
I think everyone, now it has been proved, everyone knows that slit lamp based marking is the most important. Unless you have got an online marker, this is the best thing. I mean, those bubble marker, I feel these are the, I mean, I feel it's useless because most of the time, what we do with the bubble marker, the most important fallacy is that we can mark exactly 180 degree with the bubble marker, but we cannot know the center of the cornea. And we, even with 0.5 millimeter up and below, when we are marking 180, we are away from the center, that can give error of 6 degrees in the final this calculation. And when you put in the IOL, the most important thing, when we find this, most of us, we find that once after we put in the IOL in the bag, the one set of the marker on the IOL, it matches your axis, and the other goes away. So
you can never get both your marks on the IOL on the 2 marks.
Yeah, I mean both, and then both. I mean you cannot take a chance that 50% I'm in 50% of the cases I can be right if I go by this mark or that mark.
And
both the marks are wrong.
Even if you put it in between, still you are wrong.
No, in between it's okay.
But still you are not accurate.
Yeah, not
even
accurate.
In between.
So it is because of the decentered marking, which is very common with this bubble marker. So I didn't think that
is
straight line based marking is the best thing. And I personally use BRC AccuMark, Bhaskar Rai Chaudhary, invented by our own Indian. I mean, that's very good. I feel it's a good thing to use BRC AccuMark.
Dr. Praveen, some input from you, Dr. Praveen?
So just try to congratulate Dr. Bhagyashree for that very concise coverage of correcting astigmatism. It's a 1 hour, 2 hour topic, but she compressed it very nicely in 10 minutes. And I think some very important points there as well about using the opposite clear corneal incision, something where we don't need any extra instrumentation. And if you actually look at the curve of astigmatism in regular population who's coming for cataract surgery, I think 85% of these patients can be corrected by on-axis incisions or by small modifications like doing an OCCI or maybe a small LRI. It's only the 15% who require additional correction like a toric IOL. And for the toric IOL as well, like Dr. Bhagyashree mentioned, the measurement that most of us have access to will be measurement of the anterior surface of the cornea. Now, when you talk about posterior astigmatism, again, this is something that we are hearing recently, but the magnitude of the error is not as big as it is made out to be by a lot of companies as well, who will try to sell you a device that will measure the posterior corneal astigmatism as well. If you look at the quantum of error, the difference is about 0.25. The average difference is maximum in patients who are young or patients who are very old. Between 60 and 70 years, where we have most of our cataract patients, actually the difference is not significant. But if you are putting in a multifocal lens, where even small amount of astigmatism that is residual will be perceived by the patient, that is where it is becoming more important. For a regular patient, posterior corneal astigmatism, you want to bring your expertise that little notch up, perfectly fine. But also what we've seen is patients who have some amount of residual against the rule, 0.5, 0.75, they actually do quite well from the point of view of reading vision without a big compromise on the distance vision. So astigmatism is something that we don't need to eliminate completely unless you're putting in a customized IOL like a multifocal lens. And that is where I think posterior corneal astigmatism becomes very important. But marking, like you said, Dr. Harwani sir, I think very, very important to use a marker, not with ink that tends to smudge in large areas, but something that creates sharp marks like on the slit lamp, like a needle, so that your alignment is better. I think parallax, you already mentioned how that is very important. Average error of slit lamp marking is about 4 degrees apparently. Average error of pendulum mark is about 6 degrees. So relatively similar, but there is some error there as well. And that's why people recommend using the intraoperative marker, but those are extremely expensive at this point of time. 4 to 5 degrees, I think, should be acceptable for most of our patients. But very well done. Thank you.
One last question, Dr. Praveen, about this LRI. Has anybody studied, or are there any studies? I mean, how much these LRI they induce higher order aberrations in the cornea?
Yeah, I think Dr. Bhagyashree briefly alluded to the coupling effect. The LRIs have a coupling ratio of 1. So actually, they do not change the spherical error or the aberrations in the eye at all because they're so peripheral. If you make the LRIs closer to the visual axis, then the coupling ratio changes. So recommended is not to go less than 7 millimeters. And LRI, the nomogram that Dr. Bhageshri mentioned is very useful. But in fact, if you want something more practical, there is an app on the phone, on the iPhone as well as the Android, called lricalculator.com. You can download it. It's relatively accurate. And in the OR, suddenly, if you don't have internet, you want to access something complex, it's a very simple, quick fix solution to know how many degrees you need to cut. And nowadays, I think companies are coming up with the 600 micron blades, quite easily available, not very expensive. So you have those in the OR, and quickly you can fix the astigmatism as well.
Thank you, sir. Thank you so much. Any more, any other input that you would like, Dr. Praveen sir and Dr. Sangeeta ma'am, any other comments that you would like to make, or some tips like you've been giving us this whole session, wonderful, simple tips that we can all follow in our practices?
So there's another very, very simple elementary point which I want to make is that when you're noting down the keratometry and the values, it's always better to have a print in front of you, because if the technicians who are copying it down, sometimes they might make a mistake, and then it's known that you might just flip the axis and then be in for a big surprise the next day.
Very true.
Yeah, from my perspective, nothing really, Ragini ma'am. Just wanted to say how happy I am to actually be back among a society that is that feels more like friends than a society that is not something that I'm really part of because of my geographical location. But thank you again for the opportunity to be present along with all of you.
Thank you so much. Thank you
Thank
for
you
being
for
here.
taking out the time.
Thank you very much.
Dr. Dhamorikar, Dr. Manish, Dr. Ashutosh, anybody would like to, any inputs, any comments? Dr. Parikshit Bhai, Swapnesh, Pankaj, anybody, something to contribute? I mean, such wonderful things have been spoken, but anybody who would like to ask anything, get anything clarified for everybody's benefit, or probably any other input? So
I think all the three speakers and the panelists and the discussions they've covered the entire thing.
Well, I think Dr. Ashutosh, our president of ADOS, can make some concluding remarks.
Your mic is not open, Ashutosh, sir.
Dr. Ashutosh?
Ashutosh, please unmute yourself. Ashutosh.
I'm doing okay. Am I audible now?
Yes,
yeah,
sir.
yeah.
Oh, thank you very much.
Can hear you, Dr. Ashutosh.
All the speakers have nicely covered the topic. The panelists have elaborated the topic very much, and everybody has contributed. Thank you very much to all. And shall I do vote of thanks now, or is it done by Shirish?
I think, Sirish, before that, I would like to say just one or two things. I am going to go to meet Dr. Praveen to have a look at the books that he has, the rows and rows of books that he has, the big library. My concentration was getting disturbed by all the books that I was seeing. So I'm going to come running one day. Thank you so much for being with us. And Dr. Sangeeta, it's so wonderful to see you again. And like Dr. Praveen said, it's been like a family meeting. Dr. Ashutosh, so very well done. So very well. A big congratulations to you. Dr. Anil Harwani sir, Dr. Dhamorikar sir are so senior. And thank you for all your time.
Not that senior.
Not senior. Dr. Manish Bhai. And, thank you for everybody's lovely talks, Dr. Pankaj, Dr. Bhageshri, and Dr. Naveen. It has been such a wonderful meet, and with Parikshit's leadership, and lovely, simple take-home tips for everyday practitioners, which has been so good, so good. I think there is nothing more to add, and our three musketeers, Pankaj, Sirish, and Swapnesh. I think kudos to them and Dr. Ashutosh Bhaiya's team, Bless you and bless you both.
Yeah,
Dr.
and
Sangeeta Wagh and
the
Dr.
level
Praveen for
of
being with us.
presentation would have put any metro meeting to shame. I mean, they were that good. So.
Thank you.
Exactly. The thing is, that's why there is so much of talent, and it's never come out. And I think you can see the level of presentations. Sirish?
Madam, actually, Amravati is an academic hub of Vidarbha. You just think of any modern thing, it is available in Amravati. So we follow Amravati.
Thank you, Sirish.
Yeah, because Amravati has the lady president of India. Amravati is.
Yes.
So I mean, what a lady! I mean, I've been to Amravati and it's rocking. They have to be. I'm so happy. We are so happy.
I've spent 4 years in Parathwada. Yeah.
Oh.
Yeah.
Dr. Bhuyar and Dr. Sirish.
Yeah, so I am really thank to our chief panelists, Dr. Praveen Krishna sir and Dr. Sangeeta Wagh madam for being with us, and their extremely valuable inputs and guidance. Thanks to all speakers from Amravati, Pankaj, Naveen and Bhageshri madam for their enlightening talks. Thank to team of Amravati for arranging this very valuable CME. Thanks to Dr. Parishit sir, Dr. Ragini madam for guiding us. Special thank to Dr. Raman and Dr. Atharva sir and team Entour for technical support, and all the delegates who have joined this webinar. Thank you all.
Thank you.
Thank you so much. Thank you so much.
Thank you, everyone.
Thank you.
Thank you, everyone.
Thank you.
Thank
Nice.
Very nice. Thank you.
Thank you, and thank you, Dr. Swapnesh, as well. Stay safe and good night to everyone.
Thank you so much. You too. Take care and take care of those books. I'm going to steal them one day.
Absolutely. You're always welcome.
Thank you, everyone. Good night.
Thank you, ma'am. Thank you so much.
Bye,
Thank
Sangeeta.
you.
Bye-bye.
Dr. Ashutosh, phenomenal meet. Very good
Ashutosh, are you
discussion.
there?
Very good. Dr. Manish Bhai, very good.
Nice.
Thank you, madam. Thank you.
Very good.
Yeah, Raman Bhai and Atharva, very well done. Thank you so much for everything.
Yeah,
Parikshit
thank you,
Bhai.
ma'am.
Yeah,
Parikshit
Thank you so
Bhai,
much,
you
ma'am.
are
yeah. The
back in
technical
knowledge.
team was also
By
perfect.
Entour as usual, and
Yeah,
great
flawless
going for all the
support.
3 speakers. Yeah.
All the presentations of the morning.
Swapnesh, I think this team worked so well. The two-way discussion was fantastic with the experts and the whole